Rotator cuff tendonitis. Um, Rotator cuff tendonitis is relatively common, and it's going to look a lot like shoulder impingement syndrome. In this case, though, we're specifically targeting one of the rotator cuff muscles, and the most common that's actually irritated and injured is the supraspinatus muscle. Based on the location of the supraspinatus, that's why it's the most common. It's the one that's underneath the subacromial arch, and it's the one that's really going to be predisposed to the most trauma. I mean, you can get tendonitis of the subscapularis in the front or the teres minor and infraspinatus in the back, but the most common we see due to the constant trauma during overhead activities is to the supraspinatus. When it comes to tendonitis or tendinosis, any kind of rotator cuff pathologies that's not a full tear, it's going to have that a slow onset. It is a chronic condition, so most of the times it is somewhat of a slow onset. It is broken down into both acute tendonitis and chronic tendonitis. Acute tendonitis is still slower in onset, and it's not a result of one traumatic injury, um, but it is from following. It's after you change your activity level. So if you go from taking a long time off of overhead activities and then you start to do them a lot, then that's when you're going to predispose yourself to this more acute tendonitis where you had no problems previously, you changed your level of activity, you changed the tasks that you were doing, and now you develop tendonitis. So that's more of what we call the acute tendonitis, where it just happened kind of all of a sudden. More the chronic tendonitis is a problem that lasts for a long time. Usually it happens, the problem that you've been dealing with it every time you throw, every season you have the same problem. It starts off as maybe more of a shoulder impingement syndrome, and because of that constant irritation to the area, to the supraspinatus, then you're going to end up getting these degenerative changes over time, and the degenerative changes are going to end up causing you pain and dysfunction. This chronic tendonitis, the one that's long-term, tends to be actually more common. People who do overhead activities like throwing, serving tennis, hitting a volleyball, even swimming, those overhead activities put a lot of pressure on the supraspinatus and can pinch it a lot. So usually it's the impingement syndrome that you've been dealing with for a long time can end up developing into a rotator cuff tendonitis. When it comes to signs and symptoms, they really are similar to impingement syndrome. So it's going to be somewhat important to differentiate between a rotator cuff tendonitis specifically and just general impingement syndrome. And the way you can do that is really look at the supraspinatus involvement. With impingement syndrome, you really shouldn't have any pain and weakness specifically to the supraspinatus, but just pain when you're in that in the positions, especially the overhead positions that actually pinch the structures. So that's kind of one way to figure out the difference between impingement syndrome and rotator cuff tendonitis is the muscle actually involved. So you can do a supraspinatus test to identify if the muscle is actually involved. But signs and symptoms wise, you're going to have pain deep within the shoulder. Usually if you can find the acromion, you go just palpate just inferior to the acromion. So if you palpate the acromion here, you go just inferior. You're pushing on the deltoid, but as you push in, you also are putting pressure on the supraspinatus. It might not really be a type of structure that you can elicit point tender pain, but the person generally reports pain just inferior to the acromion. So when you push on it, you may or may not elicit pain, but they'll tell you that the pain is in that area. It's going to start off with pain with overhead activities, just like any other tendonitis. It's going to start off more mild, where pain just when you're doing it, and then it's going to progress to pain with constant activities of daily living. So normal things are going to start causing pain, like anytime that you reach overhead. So you reach into a cabinet, or you try to shampoo or blow dry your hair. Whenever you're doing things overhead, it's going to start to cause pain, and that's going to be more of a severe type of a problem. When it comes to the contributing factors of why we get rotator cuff tendonitis, they're very similar to why we get impingement syndrome. It could be a result of muscle imbalance. It could be a result of a weak capsule, or it could be a result of something actually in the way causing trauma to the rotator cuff itself. So when it's actually muscular related, it could be a result of your rotator cuff or the strength of the big muscles around it. So you have decreased muscle balance between the internal rotators and the external rotators. if you have a decreased balance there, one side stronger than the other, then as you do the activity, if one side is really strong, and usually the internal rotators are very strong, your external rotators tend to be a little bit weaker, then you have one side pulling really hard, the other side is not able to counteract that, so you're going to result in more movement um, of the humerus and the glenoid fossa. It could also result in the muscles having to work too hard, especially the external rotators have to work too hard, and they could develop tendonitis over time because they're working overtime to keep the humeral head in place. Capsular laxity we talked about before. In general, we have poor static stabilization in the shoulder, but if you have the laxity, you have even worse static stabilization, and that's going to cause the rotator cuff to, cause the humerus to move around too much and have the rotator cuff work overtime. And if it's working overtime, then it's more predisposed to an overuse injury. Poor scapular control we also talked about. If your scapula is not stabilized during these overhead activities, then you're going to put your humerus is going to start to move more and put all the structures around at risk of problems. Impingement syndrome I just mentioned. Impingement syndrome is, again, it's kind of that catch-all term, and it's kind of an early on. You'll start to have pain with impingement syndrome a little bit earlier, and if it's not dealt with, then it can actually transform or get worse and lead to that chronic rotator cuff tendonitis. Unfortunately, the supraspinatus also has poor vascularization. So when it is injured, because there is poor vascularization, there's not good blood supply to the supraspinatus. When it is actually injured, it's harder for it to heal because there's not a lot of blood going to that area. So unfortunately, it's a muscle that is commonly injured, and because there's not good blood supply, that minor injury may transform into a major problem because it's not able to heal. And then the acromion shape. I mentioned this before when we talked about structures that are in the way during impingement syndrome, structures that can actually decrease the space. And I mentioned how the acromion can be somewhat misshaped. And if the acromion is somewhat misshaped, the subacromial arch is going to be a little bit smaller in those individuals. So if you look down here, the three different types, they say there's 4 types, but I have pictures that only has 3. We're looking at this. Here's the anterior side, here's the posterior side, here's your acromion, your coracoid, and your glenoid fossa. So we have our acromion. This is a type 1. This is what we want to see here because we have the coracoacromial ligament that's going to run this way. And based on how the acromion is positioned, that ligament is going to form the arch, and we have a fair amount of space in there. Pretty good space for the supraspinatus to lie, and during the activity, hopefully it won't get pinched. But then we can develop or just be born with more of a hooked-shaped acromion. And when we have that, the acromion is hooked-shaped, and it starts to become curved, where this one is straight, sticking up. This one is more curved, and when we have the coracoacromial ligament finish the arch, the space gets a little bit smaller. So that's a type 2 where there's some curve. Then we have our type 3, which is really hooked or curved, and it's taking away even more of the space. So this is just bony alignments that could end up resulting in just decreased space where the supraspinatus is going to run through here. And a type 4 would be even worse than a type 3. So the worse type of acromion you have, the less space you have underneath the subacromial arch, and the more pressure it's going to put onto the supraspinatus during overhead activities. So a lot of times when people have impingement syndrome and rotator cuff tendonitis, this chronic rotator cuff tendonitis where it's just not getting better no matter what you do, no matter how much rest, how much range of motion, strengthening, postural assessment, all that, you fix it all, and they still have these problems. Sometimes they actually go in and they shave off part of the acromion. So if you have a hooked acromion, then they actually go in and shave off the curved part because it's what's actually causing your problem. Because it's a bone, no matter how much rehab you do, it's never going to be fixed. So you actually have to go in and have a surgical procedure to take off that hook. Rotator cuff tendonitis may or may not lead to rotator cuff tear. We can have rotator cuff tears that are acute, where you have one traumatic event that actually causes this rupture. Acute tears are not near as common, especially in the younger population. It can happen. It can absolutely happen, just like any other muscle tear. When the muscle contracts too hard, it can tear, just like anything else. but that tends to be less common in the younger population. Overall, the rotator cuff in the young population is pretty strong and it's harder to rupture. In the older population is when you tend to see more acute rotator cuff tears. What we tend to see is overuse problems that end up resulting in rotator cuff tears. And we also see this in the older population. The older population is way more apt to have a rotator cuff tear than a younger population. But when we do see it in the younger population, we tend to see someone who has chronic impingement syndrome that has moved into chronic rotator cuff tendonitis. And when we've had this chronic problem that has not gotten better, we see those degenerative changes in the rotator cuff. And then we keep pushing and we keep playing and participating. We don't take a break. We don't get it fixed. We don't address the problem. They continue to throw or whatever. And then because of that, because the muscle itself is just weaker now, then it ends up rupturing. That is more common in both the athletic population and the older population. So you will see rotator cuff tears. Tends to be more the supraspinatus tendon involvement, like this one is up here, where the supraspinatus tendon that's running underneath the arch actually just ruptures from the greater tuberosity. We can have both full thickness and partial thickness tears. Partial thickness are going to be shorter. They tend to be longitudinal, so they go along the muscle, where it's not straight through across like this, but it tends to be longitudinal. There might be some fraying. It might not be all the way across, but like these may fray, where your full thickness tear tends to develop from partial thickness, and then by the end, your whole entire rotator cuff is just now detached. Your whole entire supraspinatus is just detached. So you could have a partial tear that, with one traumatic injury, then it becomes a full tear. So again, rotator cuff tears can occur acutely with just one big freak traumatic injury. Really, usually a high force is going to be involved there. More common is overuse type of injuries, where it's just a chronic problem. Then you finally get a partial tear, and then your partial tear becomes a full thickness tear, and that's what we tend to see more often. Signs and symptoms. Same kind of signs and symptoms that we're going to see with pain-wise when someone has a rotator cuff tendonitis. So you have point tenderness over the subacromial space. Because this is actually torn, the structure might be more sensitive, so you might actually get some palpable point tenderness versus just the patient reporting pain in that subacromial area. But either way, they're going to report pain underneath the acromion, and then when you palpate, you might actually palpate pain under the acromion, or palpate and elicit pain under the acromion. The big thing here is range of motion. During active range of motion, because a muscle is involved, we're going to see a lot of pain and weakness, or maybe even inability to perform abduction between 70 degrees and 120 degrees. If you remember, the drop arm test is you start straight up and you allow your humerus to fall, your entire arm to fall down to your side, and it's supposed to be a nice controlled manner. People who have a rotator cuff tear are not able to control the humeral elevation between 70 and 120 degrees. It causes a lot of pain, and if it's totally ruptured and gone, there's nothing there to support it anymore. So yes, your deltoid is working, but your supraspinatus is really important between 70 and 120 degrees of shoulder abduction. So the drop arm test will help identify that it is an actual tear. People who have more rotator cuff tendonitis might have some pain during the drop arm test, but it's not going to have that uncontrolled drop that we see with people with an actual tear. The empty can test is when you put the person's arm in scaption and then put them in internal rotation, and you just do a brake test, and that test is there to isolate the supraspinatus. So depending on, again, how torn it is, if it's just tendonitis, it's going to be pain and weak. If it's totally torn, it's just going to be very, very weak. You can't even keep your arm up in that position because there is no supraspinatus there to withstand that force anymore. Subacromial bursitis. We mentioned this. This is a structure underneath the subacromial arch. It's there along with the supraspinatus tendon and the long head of the biceps tendon. In general, it's not palpable. It's just that friction reduction like piece that's in there. This fluid-filled sac is what we call it, but in reality, it's not really a sac. When it's not irritated or injured, then it's not really a problem at all. You can't feel it, it doesn't hurt. But when it starts to become inflamed, that's when we're going to have some problems. Rotator cuff impingement or tears often lead to bursitis because of the area that it's in. Often, that's why impingement syndrome is a vague term, because in impingement syndrome, it could be the rotator cuff involved, it could be the bursa involved, or it could be the long head of the biceps tendon involved. Now we're going to try to figure out if it is rotator cuff or if it is bicep tendon. But if you're not really able to and they just have pain, it might actually be bursitis, but we're just not able to tell 100%. Oftentimes bursitis will occur with impingement syndrome or with rotator cuff pathology. So for the most part, you're probably not going to diagnose someone with subacromial bursitis, just because you're not going to be able to 100% indicate it. However, you may if you completely rule out the rotator cuff. If you do all the tests for supraspinatus and none of those tests come back positive and they still have pain, then you may actually diagnose subacromial bursitis, but more likely you'll just call it impingement syndrome. Because it is difficult to diagnose, and it will produce positive tests for impingement syndrome and oftentimes for supraspinatus tendinitis. So it's really hard to isolate this one specific injury. When it comes to the rotator cuff pathologies, there are both non-surgical and surgical treatments. Non-surgical, we call that palliative care, where we're going to modify activity. So depending on how severe it is, you need to stay in pain-free motions. So whatever sport they're playing, they're going to want to avoid doing things that cause pain, because that pain is going to irritate the entire inflammatory process. So our goal is to modify the activity in order to control inflammation. We also can control inflammation through medication and modalities, choosing the right modalities depending on where they're at, what they're feeling. Then once we get into the rehab part, we'll work on flexibility, especially posterior capsule. Posterior capsule tightness is very common in overhead throwing athletes, because during the follow-through and deceleration phase of throwing, it puts a lot of pressure on the posterior capsule, like I mentioned before, and that extra pressure, your body's going to respond by tightening up that capsule. So if you don't do stretches to help counteract that tightness, you're going to end up losing a lot of internal rotation. If you lose internal rotation, then it's going to cause an imbalance between your internal and external rotators, and causing one muscle group to work harder. So if we can address this flexibility issue, then it might help things. And then obviously the next part is strengthening the rotator cuff muscles. A lot of times this also has to deal with endurance. We want our rotator cuff to be very good at endurance so that they do not fatigue and start having to work too hard. And then scapular stabilization. So when it comes to shoulder pathologies during rehab, you're going to work on flexibility, internal and external rotation, and then you're going to work on strengthening, focusing on rotator cuff muscle endurance, and definitely scapular stabilizers. You've got to stabilize the scapula. So that's all the non-surgical palliative care. Then sometimes, if you actually have a full tear, you might actually get surgery. Sometimes it might just be general debridement. Sometimes they'll go in, like I said, and they'll cut off part of the acromion. Sometimes they'll go in and cut off part of the clavicle to increase some space. And then sometimes they'll actually go in and repair the tissue. They'll sew the tendon back together. When it comes to the rotator cuff, in repairing the actual rotator cuff itself, repairing the supraspinatus, sewing it back together, it's going to depend on the quality of the tissue. So someone who's had years and years of degeneration to the rotator cuff, to the supraspinatus, it's going to be very difficult to find both ends of the tendon and sew it back together, because both ends have been so degenerated and so frayed for so long, it's really hard to repair those. Someone who has more of an acute problem, an acute tear, those ends aren't really frayed, so you are able to sew them back together. So in the younger population, we tend to see rotator cuff repairs. In the older population, we see it, but it's just a lot harder to do because it depends on how long they've actually had that tear. A lot of times, when you're looking at 65-year-olds and older, they've had partial tears for a very long time that may have just ended up becoming a full tear. And if that happens, the tissue is just so raw and just worn out that it's really hard to sew it back together. The example that was given to me when I was a student is when you repair sew it back together in someone who is younger, it's like sewing the back together fabric. So it's two strong ends that you can sew together, and it becomes a strong new joint. not joint, but muscle. But when you're sewing together someone who's had a lot of chronic problems, it's like sewing together tissue paper, where yes, there are two sides to it, but neither side is very strong. It's not really a good base, so it's really hard to join those two together and actually have it stay. Then we have biceps tendonitis, another tendonitis. So it's going to be more. It tends to be more of an overuse type injury. It can be acute. So it could be an acute problem that leads to a chronic problem, if that makes sense. So if you do forceful extension or external rotation with the shoulder and elbow flexed. So if you think about that, forceful extension is going to the elbows. I'm sorry, the bicep brachii is responsible for shoulder flexion. So if we do forceful resisted extension, that means we're really working our shoulder flexors. You add an external rotation to that, you're going to start grinding the biceps tendon in the groove because you're pulling it apart. And then if you add elbow flexion into that, now that the bicep brachii is working at the shoulder and at the elbow. So that bicep is basically working as hard as it can. So when it's contracting, it's pulling really, really hard, and it's being ground into the bicipital groove. So when it grinds in there, you're traumatizing the tendon, giving you your biceps tendonitis. So it's not a rupture, but it's just irritation from it being pulled really, really hard through the groove, maybe even fraying the edges. You can get a dislocating or subluxing bicep tendon, where the tendon actually pops out and then pops back in. In order for that tendon to pop out, we have to rupture the transverse humeral ligament. If you remember, we have our greater tuberosity, our lesser tuberosity, and then those two together form the bicipital groove. The long head of the tendon runs through the bicipital groove, and the transverse humeral ligament is going to cover up that tunnel, basically. So the transverse humeral ligament is responsible for keeping the long head of the bicep tendon inside that groove. If through some traumatic event we actually rupture the transverse humeral ligament, then we're going to have a subluxation of the long head of the biceps tendon. So we can have acute type problems when it comes to biceps tendonitis, or we can just have the traditional overuse stuff, where maybe the biceps tendon is working too hard because we have some sort of rotator cuff dysfunction. We can also just be using our biceps tendon too much, and as it goes through that groove, if we're doing a lot of overhead activity, or we have a really tight bicep, or we're just using it a lot, then just as the bicep tendon runs through the bicipital groove, it can just get irritated over time. And because the bicep tendon does run underneath the subacromial arch, it can also be involved in impingement syndrome. So those are the different ways for us to actually get biceps tendonitis. So then here's just a picture. Here's our anterior view of our right shoulder. We have our short head of the bicep tendon coming up to the coracoid process. The long head goes through the groove. Here's your greater tuberosity, your lesser tuberosity. Then your biceps tendon goes up to this supraglenoid tuberosity, and then it's covered up and held in place by the transverse humeral ligament. So if we do not have this ligament, especially when we go into external rotation, the ligaments or the tendon is going to pop over the lesser tuberosity and have a subluxing problem. If not, if as we use it, because there's not a lot of space here, because this tendon is covered up by four sides. We have the lesser tuberosity, the bicipital groove, and the greater tuberosity, and then on top we have the transverse humeral ligament, so there's not a lot of space. So if there is irritation in here, there's not a lot of space for that swelling and stuff to go, so it can cause a lot of pain within the bicipital groove. Signs and symptoms, they're going to have pain in the bicipital groove. So it's usually very point tender. When you palpate it, you will elicit pain in the bicipital groove. They will point and tell you they have pain in the bicipital groove. They'll complain of pain whenever they're using their bicep brachii, especially in the shoulder. So they might not have as much pain with like elbow flexion and supination, but if you do shoulder flexion, then you're going to elicit more pain because the long head of the bicep tendon has to actually move in that bicipital groove, and that's where it's irritated. So usually flexion, especially past 90 degrees, is going to start to hurt. But this is an overuse type injury, so you tend not to be the worst pain in the world. You can just feel it, and it's just going to start affecting how well you can perform. If you actually have a subluxing tendon, you're going to notice it popping out whenever you go into external rotation. So when you move your shoulder into external rotation, especially in overhead activities, so when you're out either in flexion or abduction above your head, um, and you do external rotation, and then especially when you contract your bicep tendon, that's when it's going to pop out. And you may or may not be able to actually feel it when you palpate, but the person will know that it's popping out and popping back in. The two tests that we use, Jurgensen's test is specifically designed for identifying rotator cuff. Specifically designed for bicep tendon subluxation. So when this test is designed to elicit and actually pop that tendon out to see if it comes out. If that doesn't happen and they just have pain in the bicipital groove, then that's a positive test for biceps tendonitis. Then we have speed test, which is what he's doing here. Basically, it's just resisted shoulder flexion as the bicep tendon moves through this. So you're palpating the bicipital groove, you're resisting shoulder flexion, and seeing if he has pain in that bicipital groove. When it comes to treatment, because biceps tendonitis often occurs at the same time as either rotator cuff tendonitis or impingement syndrome, the treatments are pretty similar. You need to rest. You need to deal with the pain and inflammation, so that could be through modalities or medication. Then you're going to work on range of motion. Then you're going to work on strengthening the rotator cuff and strengthening the bicep and strengthening the shoulder scapular stabilizers. Okay, the next one here is your SLAP lesion. So it's a specific type of labral tear. So SLAP lesions are labral tears. There's categories of labral tears. In this case, this one is a specific location on the labrum where it's the superior labrum moving anterior to posterior. So again, looking at this picture, this side over here is anterior, this side is posterior. Here's your glenoid fossa. So in this case, the SLAP lesion is on the superior part of the labrum, moving anterior to posterior. And also, it's very important to remember that the long head of the bicep tendon is coming up through the bicipital groove, inserting into the supraglenoid tuberosity and into the superior labrum. So the biceps tendon does attach to the superior labrum at the spot where SLAP lesions occur. So in order to get a SLAP lesion specifically, oftentimes it's from some sort of connection to the bicep tendon, because the bicep tendon runs there and that's the exact location. Usually a lot of tension from whatever activity through the long head of the bicep, if the tension is bad enough or high enough, that it actually can cause a labral tear just because the bicep tendon is pulling it off. We see this a lot in the follow-through of pitching because the bicep tendon is working hard to help control the location of the humerus in the glenoid fossa. We also see it a lot depending on what you're doing, type of activities, compression. So if you're doing a lot of weight bearing on your hands, you can get SLAP lesions, or any kind of traction, inferior traction specifically. Again, not overly common mechanisms because you're not often weight bearing on your hands, but things like gymnastics or cheerleading, maybe some dance will put you in those positions. So that could all be why you get these SLAP lesions. Generally speaking, labral tears are relatively hard to diagnose. The signs and symptoms are not overly specific. So a lot of times people come in and they're going to complain of pain around their AC joint coracoid process, between those two. So your AC joint's up here, coracoid process here. So you're going to complain of pain deep in your shoulder underneath the coracoacromial arch. Well, if you remember, that's the same location where impingement syndrome hurts, where rotator cuff tendonitis or tears can hurt. So it tends to be somewhat difficult because it's not very specific in the location where it hurts. You're not going to get much point tenderness at all because it's so deep. So it tends to be very vague. They complain of pain during movement that's relieved by rest. Well, that could be said the same for impingement syndrome or for rotator cuff tear. So again, it's not overly specific. So what we actually tend to, when dealing with SLAP lesions, when someone comes in complaining of pain in their shoulder, we tend not to be able to diagnose SLAP lesions right away, or labral tears in general right away. We tend to try to deal with them conservatively. So we rest, we do stuff for pain and inflammation, then we work on range of motion, we work on strengthening, and when all that doesn't work, then we try to we send them to get an MRI to see if it's a SLAP lesion. Because a lot of the special tests and whatnot, they're not terrible, but they're not the best either. So it actually is pretty hard to diagnose a SLAP lesion until you try to rule everything out first. What they may help, it may help indicate that they have a labral tear or slap lesion. A throwing athlete may report a dead arm or the inability to control the velocity or accuracy of the throw. So they feel like they're not able to control their shoulder um, during their pitch or during their throw, and that may help indicate a labral tear. But again, that's not overly specific. We may have some people come in saying they feel that there's clicking within the joint. Um, the labrum is there, and if it's torn like this, as the humerus rotates, it might catch or click, and that might help clue you in that it's a labral tear. But again, overall, they're relatively hard to diagnose. If you do have a labral tear, then you are going to have to get surgery to put it back together. Um, so post-surgical treatment depends on the type of repair they did. It also depends on how much the bicep tendon is involved. So here's your bicep tendon coming in. Here's your labrum, and they just sewed it back together. Um, so if you do have a labral tear and you have surgery, then it's going to be a fairly long process because whenever you put something back together and you have surgery to put it back together, it just takes longer to heal, especially when a tendon is involved. So if the tendon was not involved, you'd be able to move that joint a lot quicker. But because the bicep tendon is involved in that area, you're not going to be allowed to contract your bicep for a long time, 6 to 8 weeks, because every time you contract your bicep, it's going to pull the labrum back off. So it's going to be a long, slow process. Sometimes they'll just go in and do some debridement. If you're not ready for a repair, if you don't have time to sit out, they might just kind of go in and clean things up, get some of the extra tissue out of there. That might help relieve some of your pain. Okay, and then the last pathology we're going to talk about is thoracic outlet syndrome. And this is not so much an actual shoulder injury, but because it's near the shoulder and it affects the upper extremity, we're going to talk about it here. But thoracic outlet syndrome is going to be caused by something compressing either the brachial plexus, the subclavian artery, or the subclavian vein. So if you look at these pictures here, we're looking at this guy's left upper chest, basically, right before his shoulder. And up close, we see that here's the brachial plexus coming out. This is the nerve roots, and the brachial plexus travels underneath the clavicle and above the first rib. We also have the subclavian artery and subclavian vein. So the artery is red, the vein is blue. And they're also going to come right off the aorta, and they're responsible for feeding and taking away the blood from the entire upper extremity. So this is the one artery that's going to start and bring all the blood to the upper extremity. Both of those also travel underneath the clavicle and above the first rib. So in thoracic outlet syndrome, basically one of these three things or multiple of these things are going to be compressed. So generally there's a couple of different places where compression can occur. We can have compression between the clavicle and the first rib. So we actually have a smaller space here, and during your movement or the positioning of your posture or whatever it is, it's causing pressure between the clavicle and the first rib. We also can have compression between the pec minor and the rib cage. So the pec minor is going to be over here, heading toward the coracoid process. It's also in the area, so if the pec minor is really tight, it can compress those structures. And tightness between the anterior and middle scalene. So if you look in this picture, and there's another picture on the next slide, but here is your anterior scalene. Scalenes are three tiny muscles running vertically. Here's one, and there's one right behind it. So we can actually have tightness of the anterior and middle scalene, and if these two muscles are tight, it's going to end up compressing the spinal nerve roots when they come out and form the brachial plexus. So those are the three ways that we can see compression that could possibly cause thoracic outlet syndrome. So here it is again. The subclavian vein is not in this picture, but here's your subclavian artery running underneath the clavicle and above the first rib. So we can have compression here. I've also been told that some people have a false rib or an extra rib, and what that means is here's your first rib technically, but then they have on the transverse process of the vertebrae above, so your C7, where T1 is going to start your ribs. So all the thoracic vertebrae have a rib attached to them. The cervical vertebrae should not have a rib attached to them. But what happens sometimes, just genetically in people, that these transverse processes that stick out the side, they actually grow a little bit too long, and they end up putting pressure in that. And if we have this extra long projection sticking out here, then it's going to end up taking away space, putting less space between the clavicle, less space between the first rib and that cervical rib, and possibly compressing the subclavian artery or vein. And then here's a picture of your middle anterior scalene, and you have your middle and posterior scalene, and your brachial plexus or your nerve roots are coming out between the anterior and middle, and that could possibly cause some restriction. Then your pec minor is going to be over here, and that could possibly pull the could actually compress them themselves or pull the scapula forward enough to cause compression there as well. So there's a couple different types of thoracic outlet syndrome. We can have a neurological problem, we can have a vascular problem, or more of a non-specific problem. Non-specific is the most common, but it's also kind of difficult to figure out. Thoracic outlet syndrome is talked about a lot, but tends not to be overly common. But more recently, I have heard more about it. But when you start to try to diagnose thoracic outlet syndrome, usually you have, we'll talk about more of the neurological part and then the vascular part, which could be artery or vein. So obviously, if you have a neurological problem where the nerves are actually disturbed somewhere or pressed somewhere, squished together. So whether it's when they come out of before they become the brachial plexus and there's compression between the anterior middle scalene, or whether it's pinched somewhere, we are going to have neurological sensations. So if we know a nerve is involved, because we're going to have neurological sensations: numbness, tingling, shooting pain, loss of sensation, loss of motor function, something that's going to be neurological. So you'll know what structure is going to be involved because it's going to basically tell you based on the signs and symptoms. So a lot of times the ulnar nerve is involved, sometimes the median, just because they're closer to the first rib. So if something is going to be compressed, it's going to be one of those two. So if we understand where those nerve roots run, we might start getting some neurological sensations along that specific nerve distribution. So we might feel it behind our elbow, we might feel it in our forearm, it might go all the way down to our hand, because there are specific nerve patterns. So like your pinky and ring finger are innervated by the skin around those, is innervated by the ulnar nerve, where your middle finger, your index finger, and your thumb are all innervated by the median nerve. So if you're having problems with just half of your hand, you can try to figure out that yes, it is a neurological problem and it's affecting the ulnar or the median nerve. But very classic nerve type of symptoms. Then you have your vascular symptoms. If an artery is disrupted, then you're going to have decreased blood flow. So if an artery is pinched somewhere, the blood flow is going to be decreased, and you're going to be able to tell that through decreased pulse, decreased capillary refill. Maybe you'll have cold hands. Maybe you'll have a little bit loss of color. Whatever it is, blood is not getting there. So you can tell that it's arterial because blood's not actually getting there. If a vein is involved, we will probably see the blood can't get out. The fluid can't get out. So you tend to see swelling in the hand or in the hand and wrist area. You might even lead to blood clots because the blood is just sitting there because the subclavian vein is pinched high up in by your neck. The blood can't get out of your arm, and if it can't get out, it's going to cause that swelling and possibly blood clots. So we do the three primary tests for thoracic outlet syndrome: your Adson's, Allen's, and military brace. Adson's, when you turn your head toward the side you're testing, is looking for tightness in symptoms for the scalene, so between the anterior and the middle scalenes. Allen's test is going to be looking for tightness and problems with the pec minor. Military brace is going to be more of a general type test for thoracic outlet syndrome. We're going to refer this to a doctor. We can't really do much about it. We can assess some of the postural issues and muscle tightness if we think that part of this is going to be a result of of tight muscles or poor posture, then we can try to address it. But we want to make sure that we're dealing with the problems. So even if we're going to address it, we should still send them to the doctor for referral. And I lied. This is the actual, I think, last pathology. Your brachial plexus pathology. Again, we're going to talk about it in this chapter because even though it's not a shoulder pathology, it's by the shoulder and it's going to affect the upper extremity. Brachial plexus pathologies are actually relatively common, especially in sports like football. Um, Generally, are going to be a result of an acute trauma. So some sort of trauma has happened, and it's going to result in neurological problems. This is also called a burner or a stinger. So you might have heard that on the football field, or on TV, the announcers or whatever might have said those things. But technically, it is called a brachial plexus neuropraxia. So the technical term for a burner or a stinger is brachial plexus neuropraxia. And if you remember um, the grading scale of nerve pathologies, neuropraxia just means stretching of the nerve. So no permanent damage, just the stretching. Um, we tend to hurt the brachial plexus and have that neuropraxia as a result of a traction force, a pulling force. This occurs very often in football because when you go to tackle someone, your head is tilted to the side a tiny bit, and you actually hit the person with your shoulder. So if you hit him with your shoulder and your head is forced to the side, you are stretching out your entire brachial plexus. So very forceful compression down, the head is tilted sideways. That's going to lengthen the brachial plexus, stretch it, and give you your neuropraxia. We can also have a compression mechanism, and it's the same exact mechanism. The shoulder is forced this way, the head is forced this way, but instead of feeling the symptoms on the side that's being stretched, we actually feel the symptoms on the other side where the head is being turned toward. Because what's happening is we're actually compressing the nerve roots up by the vertebrae. So the traction injury is going to be when they're actually stretched out. The compression injury is on the opposite side, where because our head is being turned or being laterally flexed so much, we're actually compressing the nerve roots when they come out of the vertebrae. The traction one is way more common. You can also have a direct compression if you get hit very hard right above the clavicle or right at the clavicle, or if you have a fractured clavicle. Those are all going to be issues that you need to deal with because there are some major structures. The brachial plexus is here, but again, we also have that subclavian artery and vena right there. So direct compression can also put a lot of stress or tension on the brachial plexus. Erb's point is just a point. It's the most superficial location of the brachial plexus, so it's considered right here. So if you palpate your middle clavicle and you push right behind it, and you actually push it on yourself, even though you're not injured, it doesn't feel very good, and you get the kind of a neurological sensation. That's the most superficial path of the brachial plexus. So just kind of do know where that's at as well. So I talked about the traction mechanism when you do have your head forced apart and the brachial plexus actually um, stretches. These tend to resolve relatively quickly. They are not allowed to return to play until all symptoms are gone, but usually the traction mechanism is not overly severe. The compression mechanism, because you actually put compression on those nerves, it might last for a little bit longer. And every time that you move your head in that direction and compress them again, you're going to have possible recurring symptoms. So traction is a lot better. Compression is a lot worse because you actually hurt multiple nerve roots at the location where they come out of the vertebrae, and every time you move your head to that side, then it could cause recurring symptoms. Over time, if you have multiple compression mechanisms, we could end up resulting with spinal stenosis. Spinal stenosis is a narrowing of pathways. So there's a foramen where a circle that's formed where the nerve between two vertebrae, where the nerve root actually comes out of the vertebrae. With repeated trauma over time, your body adjusts and adapts and actually puts more bone there. This is a long-term problem. You tend to see this a lot in the PT clinics when you have people that are a little bit older, not current athletes but ex-athletes who come in complaining of a lot of neck pain, a lot of neurological symptoms, and a lot of them are ex-football players who've had repeated trauma that ended up resulting in spinal stenosis. So you're not going to see this right away, but over time it can build up from this constant trauma. These are really easy to diagnose, either one. Usually what happens, the person comes running off the field. Their arm is usually hanging at their side. They might be kind of flexing and extending their fingers of their hand, kind of shaking their hand because it feels, people have reported a burning sensation. it feels like an electrical shock has been sent down your arm. People say it feels like I have hot water running down my arm, but usually the arm is hanging at their side. They don't have a lot of control over it. And then when you do your upper quarter screen, you're going to have decreased strength and decreased sensation in any area that's affected. So whatever part of the brachial plexus was actually stretched out, those areas are going to have decreased neurological sensation and motor function. So it's a pretty obvious type of injury. You are going to do your upper quarter screen, which we'll have a separate lecture for that. But basically, you test them, figure out what area is injured, and then you wait and you test them again, and they're able to return to play when they have full strength, full range of motion, and full sensation. If they can prove to you and they can pass your upper quarter neuroscreen, then they can return to play. So usually it can last between a couple minutes up to maybe a half an hour, maybe an hour. If you see that the symptoms are lasting longer than that, you're probably going to want to refer them.